predicting exactly how someone with cancer will respond to treatment, even with all our incredible medical advances, is still one of the biggest puzzles doctors face.
It really is.
They pull together everything they can, test results, scans, their own experience, but getting a truly clear picture of your individual journey, tailored precisely to you, well, it often feels just out of reach.
And that's the core challenge, isn't it? I mean, we have mountains of data for each patient in the modern healthcare system.
Right.
Detailed medical histories, every lab result, scans, genetics, pathology reports. It's all there.
But the way we use it now it often relies on just one or two things, like a single gene marker or just the staging score.
Exactly. And those things, while important, don't capture the incredibly complex interplay of everything going on with that patient and their specific tumor.
It's like trying to predict the weather by only looking at the wind speed. You're missing the temperature, the humidity, all the other systems.
That's a great analogy. And a lot of the advanced tools researchers develop, well, they often don't quite make it into the clinic.
Why is that? Too complex.
Sometimes, yeah. Or they just don't look at that full, unique context for each person. They're still missing pieces.
Which brings us to some really exciting research we're diving into today. What if you could take all that real-world data, the messy, diverse information from actual patient care, not just those super-controlled clinical trials.
Right, the kind of data doctors see every day.
And combine it with the power of seriously advanced AI.
And crucially, AI that can actually show its work. Explain why it thinks a certain factor is important for your specific prognosis.
Yes, that explainability factor feels huge.
Absolutely. That transparency is key if doctors are ever going to trust and use these tools. So this deep dive is into a fascinating article published in Nature Cancer. It's titled Decoding Pan-Cancer Treatment Outcomes Using Multimodal Real-World Data and Explainable Artificial Intelligence.
Okay, decoding outcomes.
Yep.
So let's unpack this. Our mission today is to dive deep into the study, figure out how they tackled this massive challenge using data from over 15,000 patients.
15,000, yeah, across many cancer types.
How this explainable AI, or XAI, helped them see things maybe traditional methods couldn't, what surprising factors they found, and what this could actually mean for the future of personalized cancer care.
It's about cutting through the complexity and jargon to give you the essential insights.
Let's get into it. So we touched on this, but the fundamental issue is all this data exists.
A wealth of clinical data, yeah. Labs, images, genetics, history.
But personalized medicine, especially for predicting prognosis, it hasn't fully arrived for everyone yet.
Right. And the researchers really emphasize it's not usually a lack of data that's the problem. It's that the traditional approaches often just focus on one thing.
Like just the TNM stage, maybe?
Or just one specific gene mutation, for example. These limited scoring systems, they just can't capture how all those patient factors and tumor factors interact. It's rarely one isolated thing driving the outcome.
Makes sense. And you mentioned earlier that many tools developed in labs don't make it to the clinic.
Yeah, often because they don't consider the full context, or maybe they're just too difficult for busy clinicians to integrate into their workflow effectively.
Okay, so here's where this study offers a potentially powerful new direction. They talk about integrating all these diverse data sources. Multimodal data, they call it.
Exactly. Pulling together everything they could get their hands on for each patient. Clinical exam details, loads of lab results, imaging data, genetics, medical history, treatments, the works.
And then using machine learning, AI, to find patterns and all that complexity.
Yes, leveraging the power of modern AI models that can handle these huge, complex data sets. But the really crucial step, the kind of game changer here, is adding explainable AI.
XAI. Explainable AI, is that the part that, lifts the lid on the AI's black box? It tells you why it's making a specific prediction for that specific patient.
Precisely. Instead of just spitting out a risk score like this patient is high risk.
Right.
It aims to tell you, okay, this patient is high risk because of factors X, Y, and Z, and here's roughly how much each of those contributed for them. This study used specific XAI methods, one called layer-wise relevance propagation, or LRP, applied to their AI model, to really decode the prognostic factors using this huge data set of real-world data, or RWD.
Real-world data. Okay. So let's get into the nuts and bolts. How did they actually do this? You mentioned a massive data set from actual patients.
Absolutely. They gathered this multimodal data from over 15,700 patients treated at a big German university hospital. This was between 2007 and 2022.
So this isn't some small cherry-picked trial group. This is real clinical practice data.
Exactly. The kind of messy, complex data you see in the real world.
15,000 is a lot. And how many different types of solid tumors were included?
They covered patients with 38 different solid cancer types. The most common ones, as you might expect, were lung cancer, sarcomas, and breast cancer.
And the sheer variety of data points they included for each patient. The article mentions hundreds of variables.
Oh yeah, they really cast a wide net. Around 350 different variables per patient. It covered demographics, age, sex, clinical exam findings like performance status, how well the patient is functioning.
Right, ECOG status.
Exactly.
Yeah.
Vital signs, a big panel of lab tests, standard blood work, but also specific tumor markers, inflammation markers like CRP.
And you mentioned they even looked at body composition from CT scans. That's not typical.
No, it's not. They measured things like muscle volume, fat volume, derived right from the CT images patients were already getting. Plus genetic data, of course, cancer staging like TNM, detailed pathology reports,
Wow.
and extensive medical history comorbidities coded using ICD codes, prior procedures using OPS codes, even smoking status, and the exact location of any metastases.
So like 9 different locations for mets.
Yeah, they mapped it out. And the treatment itself, the specific drugs used in their first line of systemic therapy, that was included too.
They really try to capture everything.
The goal was the most comprehensive snapshot possible before that first treatment started.
Okay, so they have this incredibly rich, complex data set.
Right.
What kind of AI model did they actually use to make sense of it all?
They used a deep neural network. That's a type of machine learning model that's particularly good at finding really intricate patterns in large, complex data like this.
And what was it trying to predict?
They trained it to predict 2 main outcomes: overall survival, or OS, and time to next treatment, TTNT. Basically, how long patients lived and how long until their disease progressed enough to need a different treatment.
Okay, survival and treatment change.
Yeah.
And the explainable part, how did they get the AI to show it's working?
That's where the layer-wise relevance propagation, LRP, comes in. So after they trained the neural network, they applied LRP. You can kind of think of it as shining a spotlight backward through the trained AI model
Oh, okay.
to see how much each piece of input data, every lab value, every staging detail, every comorbidity recorded, how much it contributed to the final prediction for that specific patient.
So for me, it could say, okay, your prediction is influenced most strongly by your tumor stage, maybe your age, and this specific lab result.
Precisely. LRP assigns what they call a risk contribution score, an RC score, to each variable for each individual. A positive RC means that variable's value, like maybe a high CRP or being older, push the prediction towards a worse outcome for that person.
And a negative RC means it pushed towards a better outcome.
Exactly. More favorable.
And they combine these, the original value, like the CRP number, and its AI-assigned risk contribution, to create these AI-derived markers.
Aid markers, yes. So it's not just CRP is high, it's CRP is high, and the AI saw this as a significant risk factor in this patient's specific context. Adds that crucial layer.
That makes a lot of sense.
And a really interesting part of their approach, too, is that they trained the AI not just on individual cancer types separately, but on the combined data set of all 38 types.
The pan-cancer approach. Why do that?
Yeah.
Wouldn't different cancers be, well, too different?
That was the hypothesis to test. The idea was that training on a much larger, more diverse data set might let the AI learn more fundamental prognostic relationships, things that are relevant across different cancers, even if their specific importance might vary by cancer type. They then compared this pan-cancer model to models trained only on single cancer types.
Okay, the approach is clear. So the big question, how well did the AI actually do at predicting outcomes?
The performance was actually quite impressive. The pan-cancer AI model was very effective at sorting patients into clearly distinct risk groups for both overall survival and time to next treatment.
So you could see the separation on the survival curves.
Yeah, visually, the separation between the low risk, medium risk, and high risk groups predicted by the AI was really clear.
And crucially, did it do better than the standard prognostic scores that doctors commonly use today?
Yes, significantly better. The paper shows the XAI model consistently and substantially outperformed common scores like the UICC staging system.
Okay, the stage grouping.
The ECOG performance status, which measures how well a patient can function day to day.
Right.
the Charlson Comorbidity Index, which tallies up other health problems, and the Modified Glasgow Prognostic Score, which uses CRP and albumin levels.
Can you give us a feel for how much better, like with the numbers?
Sure. They used a common metric called the C-index, where 0.5 is basically random guessing and 1.0 would be perfect prediction. The XAI model consistently scored around 0.75 for overall survival prediction.
Okay, 0.75. And the others?
Well, compared to that, UICC staging was around 0.56, ECOG was about 0.67, Charlson Comorbidity was 0.63, and the Glasgow score was 0.59.
Wow, okay, so 0.75 versus mostly high 0.5s or low 0.6s. It's a pretty clear difference.
It's a definite step up in predictive accuracy, yeah.
And that pan-cancer training idea, did training on all 38 cancer types together actually help?
It did seem to. The results showed that training the model on the combined pan-cancer dataset led to significantly better overall performance compared to training separate models for each individual cancer type.
Interesting. So learning from the whole group helped.
It suggests that learning from that collective experience, even across different cancer entities, helped the AI build a more robust general understanding of prognostic factors. Yeah. The average OSC index went from 0.72 for single cancer models to 0.75 for the pan-cancer one.
And validation, they tested this on data the AI hadn't seen before, right? Mm-hmm. From a different place.
Absolutely critical step. They validated the whole approach using an entirely independent data set. This one was from the U.S., from a big electronic health record database called Flatiron Health.
Okay.
It included over 3,200 lung cancer patients. And the key finding was that the importance assigned to different markers by the AI, those risk contributions were remarkably consistent between the original German dataset and this completely separate U.S. dataset.
So the patterns held up.
They really did. The correlation was very strong, suggesting the AI wasn't just overfitting to the first data set. The patterns it found seemed to be generally applicable, at least for lung cancer in this validation.
Okay, so the performance looks strong, the pan-cancer approach seems beneficial, and it validated externally. But the real power, like you said, feels like it's in decoding things, finding insights we couldn't see before.
Exactly. This is where the explainability, the LRP method, really shines. It allowed them to look at the risk contribution, the RC, of every single one of those 350 variables for every single patient.
So what did they learn about individual markers doing that? Any surprises?
Well, across the whole group, they confirmed some things we already kind of know, like older age and high CRP, that inflammation marker, generally pointed towards a worse outcome. No huge shock there.
Right.
But they also highlighted some factors that might be less recognized. High levels of FT3, that's a thyroid hormone.
FT3.
Interesting.
Yeah.
Also high PD-L1 expression, which makes sense with immunotherapy being important now, and even higher abdominal muscle volume measured from the CT scans. These generally contributed to a more favorable prognosis.
Wait, FT3 being a top prognostic factor across many cancers. That feels new. Is that something clinicians routinely focus on for cancer prognosis?
Not typically, no. Not as a primary marker across such a broad range of cancers. The study explicitly suggests its importance might be significantly under-recognized clinically. That's a really fascinating potential insight the AI dug up.
That is fascinating. And beyond just individual markers, you mentioned the AI found interactions between them.
Yes, and this is one of the most powerful aspects of this XAI approach. It's not just looking at markers in isolation. Out of thousands of pairs of variables they looked at, over 1,300, 17% showed significant interactions.
Meaning the importance of one marker depended on the level of another one.
Exactly. The contribution of marker A to your risk depended on the value of marker B.
Can you give an example? That sounds really key to getting that personalized context.
Absolutely. The study gives a great one involving CRP, that inflammation marker we mentioned. So high CRP levels generally contributed strongly to a patient's risk for a poor outcome. That's known.
Okay.
But the AI found that this negative contribution from high CRP was particularly strong when the patient's platelet counts were low. If the patient's platelet count was high, the influence of that high CRP on their overall risk was much less pronounced, according to the AI.
So high CRP plus low platelets, particularly bad, but high CRP plus high platelets, maybe not as worrying.
That's what the AI seemed to be suggesting for those specific patients. Now, elevated CRP and elevated platelet counts are both known individual prognostic factors, but the AI identified this specific interaction effect, CRP's impact, being modulated by low platelets, which hadn't really been clearly described before.
Wow. So the AI isn't just adding up risk factors like points on a checklist, it's seeing how they influence each other depending on the specific combination in that one person.
Exactly. It's seeing the context. That's something traditional statistical models really struggle to capture at this scale. They also looked at which markers were most important overall across the whole data set. They calculated something called marker importance, or MI.
And you mentioned earlier that a smaller subset of markers drove most of the AI's decisions.
Yeah, they found that roughly 90% of the neural network's decision-making process could be attributed to just 114 key markers out of the original 350.
Okay, still over 100, but narrows it down a bit.
It does. And the top 5 most important markers for predicting overall survival across all patients were CRP, FT3, ECOG performance status, M stage, metastases, and LDH, lactate dehydrogenase.
There's FT3 again, right near the top.
Right. Again, really notable how high that thyroid hormone ranked in overall importance.
What about other things like comorbidities or medical history? Did the AI pick out specific health issues as being particularly influential?
Yes, it did. Certain comorbidities consistently contributed to poor outcomes, and they generally make intuitive sense. Things like having severe pain, significant respiratory problems, ascites, which is that fluid buildup in the abdomen, or having secondary cancers pop up in the respiratory or digestive tracts.
Those sound like markers of advanced or difficult disease. Were there any surprising findings among the comorbidities?
Well, interestingly, there were some diagnoses, like documented heart failure or even gastritis duodenitis, that were sometimes assigned favorable risk contributions by the AI.
Favorable. How could heart failure be favorable?
The authors speculate this might be an effect of documentation bias in the real-world data. Perhaps patients who had these conditions explicitly documented were, paradoxically, otherwise stable enough or well-monitored enough to receive systemic therapy, whereas sicker patients might not have had such non-cancer diagnoses noted in the same way right before starting cancer treatment.
Okay. So it highlights the complexities of using real-world data. You're not just learning about the biology, but also about how healthcare information gets recorded.
Precisely. It's a nuance you have to consider. The AI also showed very clearly how the importance of different markers varied quite significantly depending on the specific type of cancer.
Right. So the pan-cancer training allowed it to learn general rules, but the explainability part then lets you see the cancer-specific details.
Exactly. It validated a lot of expected findings, like, yes, the tumor marker CA19-9 is really important for pancreatic and biliary cancers. Makes sense.
Okay.
Or that the presence of liver metastases is particularly critical for prognosis in many digestive cancers. Thyroid cancer, rectosigmoid cancers, also expected. HbA1c, the diabetes marker, important for pancreatic and liver cancers. CEA, important for colorectal cancers. Stuff clinicians would largely recognize.
So it confirms the known stuff. Did it find any less obvious associations?
It did find some previously less explored or emphasized associations. For example, that CT-derived abdominal muscle volume seemed most important for predicting outcomes in vulvar, uterine, and testicular cancers.
Muscle volume for those specific cancers. Interesting.
Yeah. Or AST, a liver enzyme, showed high importance not just for liver cancers as you'd expect, but also for urethral cancer. ALT, another liver enzyme, seemed important for vulvar and ovarian cancers. ECOG performance status was particularly critical for pancreatic, prostate, and liver cancer outcomes. And FT3, our surprising friend,
Where did that pop up specifically?
showed particularly high importance in testicular cancer, alongside its known relevance in thyroid and brain cancers.
It's like the AI is painting these different risk signatures depending on the cancer type, pulling out factors, some expected, some less so, that matter most for each one.
That's a great way to put it. And they took this dynamic view even further. Using a method they developed called Explainable Kaplan-Meier plots, they could actually visualize how the importance of different markers changes over the course of a patient's disease journey.
Changes over time. So what's important early on might be different from what's important later.
Potentially, yeah. Especially when they looked at patients who unfortunately had shorter survival times.
So then AI's focus shifts as the disease progresses or worsens.
It seems to. Markers like the ECOG performance status, CRP levels, and LDH levels were pretty consistently highly prognostic throughout the disease course. They were always important indicators.
Okay, those are steady indicators.
But other markers really surged in importance, specifically in patients who had very short survival times, like just a few months.
Which ones?
Markers that clearly reflect acute organ dysfunction. Things like low total serum protein, abnormal blood clotting time, prothrombin time, and low oxygen saturation. These became highly predictive right at the end, suggesting the AI was tuning into that rapid physiological decline.
That makes sense. The body failing.
Yes. And here's another counterintuitive one. M staged the presence of distant metastases. While it had high importance overall, its relative influence actually decreased compared to T stage, local tumor size, and N stage, lymph node involvement, for predicting outcomes in those patients who survived only a very short time, like a few months.
Wait, that's really counterintuitive. You'd think metastases would always be the dominant factor predicting very short survival.
You would think. But the AI seemed to see that in the immediate short term, for those patients declining very rapidly, factors related to the primary tumor burden and local spread, T and N stage, seemed to momentarily override the influence of distant disease in predicting that imminent outcome.
That's subtle.
Very subtle. They also saw cancer-specific changes over time, like PD-L1 expression being most important for lung cancer prognosis, which aligns with immunotherapy use, or certain tumor markers like AFP for liver cancer being important throughout, but others like CA19-9 or CA125 becoming more important right near the end of life for those patients.
This level of dynamic, context-aware understanding, seeing how important shifts based on time, interactions, cancer type, it feels really difficult to achieve with traditional stats.
Extremely difficult, which leads directly to how this could potentially be used in the clinic. The researchers proposed taking these AI-derived markers, the AID markers, showing the value plus its contextual risk contribution, maybe highlighting key interactions,
Right.
and presenting them in something they call a clinician's guide.
Like a personalized prognostic dashboard for each patient.
Precisely. Imagine a clinician seeing a patient's lab results, say their CRP level, but next to it, instead of just seeing if it's high or low compared to a normal range,
Yeah.
they see how much that specific value in the full context of all that patient's other data is contributing to their predicted risk according to the AI. The study illustrated this beautifully with some example patient profiles from Figure 5 in their paper.
Okay, walk us through one or two. How would this guide look?
Sure. So they showed patient 1. This person had many factors you'd conventionally see as unfavorable. Older age, high BMI, but also weight loss, poor performance status, specific symptoms like breathing difficulty, aphasia, pain, plus advanced T&M stage, including liver metastases.
Tough case.
Definitely. The AI guide wouldn't just list these, it would visually highlight which factors, like the liver metastases and perhaps the performance status in this case, were the strongest drivers pushing the AI towards predicting a highly adverse outcome for this individual.
Okay, so it pinpoints the key negative drivers. What about someone with a more mixed picture?
Right, patient 2. This person was older, had low lymphocyte counts, both contributing negatively, but they had few other comorbidities, crucially no liver metastases, and they were receiving pembrolizumab and immunotherapy.
Ah, the treatment context matters.
Exactly. The AI assigned favorable RCs to the immunotherapy in this specific patient's context. So the overall prediction was for an intermediate risk profile, and the guide would show why, highlighting the negative contributions of aged lymphocytes, but also the positive contributions from the lack of mets and the specific treatment.
Okay, I see. And what about that really counterintuitive one? The patient with elevated CRP, which is usually a worry sign, but the AI predicted favorably.
Yes, patient 3. That's a perfect example of the AI potentially seeing context and interactions that we might miss. The AI guide for that patient showed the elevated CRP value, but the risk contribution bar next to it indicated it was not detrimental in this specific case.
Oh.
Well, the study suggested the AI might be seeing this because that particular patient also happened to have a high platelet count and maybe low urea nitrogen levels. Remember that interaction we discussed?
The CRP and platelet interaction.
Exactly. The AI might have learned that in patients with that specific combination, high CRP but also high platelets, low BUN, the usual negative impact of the CRP is somehow mitigated or counteracted.
That is incredible. The AI is essentially overriding a standard clinical red flag based on the subtle interplay of maybe 2 or 3 other data points that modify its meaning for that person.
That's the potential power. It's personalized context at a really deep level. It offers a way for clinicians to not just get a risk score number, but to understand the why behind that score for that specific patient.
Which could lead to more nuanced conversations, maybe different treatment intensity considerations.
Potentially, yeah. More personalized goal setting, more informed discussions about prognosis based on their unique profile.
So this study really feels like a powerful validation, combining massive real-world data, multimodal data, with explainable AI. It seems it really can decode these complex prognostic factors and do it better than traditional methods.
It absolutely seems to point in that direction.
Yeah.
And the pan-cancer approach feels very current, aligning with this trend in oncology where treatments are increasingly guided by biomarkers that might apply across different tumor types, not just the organ of origin.
And that explainability piece, the XAI, seems absolutely essential for getting this into practice. Doctors, patients, regulators, they need to understand why the AI is suggesting something, not just take it on faith.
Transparency is completely vital, both for building clinical trust and, increasingly, for meeting regulatory requirements around AI in medicine. And you can imagine with hospitals becoming more digital,
Yeah.
an approach like this could potentially be integrated right into the electronic health record system, maybe providing near real-time prognostic insights based on the latest data flowing in.
Of course, using real-world data isn't without challenges. Things like potential biases in how data is recorded or confounding factors you can't easily control for. Did the study talk about those limitations?
Oh yes, they definitely acknowledge those complexities. RWD has inherent issues like potential documentation bias, remember the heart failure example,
Right.
or selection bias. This cohort only included patients receiving systemic therapy, for instance. And confounding is always a risk in retrospective data. They used some computational methods like input dropout during training to try and mitigate some of this, make the model more robust.
But it's not a replacement for clinical trials.
No,
Right.
absolutely not.
Yeah.
They are very clear that this kind of RWD and XAI approach won't replace randomized controlled trials, which are still the gold standard for proving cause and effect for treatments. But what it can do is generate really powerful hypotheses, identify potential subgroups, and help design smarter, more targeted RCPs in the future.
It feels like a major step, though. A step towards truly personalized cancer prognosis, getting beyond those simple scores to really grapple with the dynamic, complex interplay of thousands of data points for each individual.
I think that's right. And the key takeaway for me is that prognostic factors aren't static things. They aren't universal rules. Their importance can change dramatically depending on your complete individual profile, your specific cancer type, how your disease is progressing over time, and the interactions between all those factors.
And AI, especially explainable AI, is starting to give us the tools to finally see and maybe even understand those incredibly complex shifting relationships that define an individual's cancer journey.
Exactly.
Which really makes you wonder, if AI can sift through thousands of data points from your blood tests, scans, history, genetics, and more, finding these hidden interactions and dynamic shifts influencing your cancer journey, just how much more potential is still locked away in all the other health data we collect every single day. What other seemingly small, maybe overlooked details about our health might hold incredibly significant hidden clues, just waiting for the right tools, the right AI, to finally unlock them.